So today, I'm Doris Hansen from Moffitt. Thank you for having me today. Very privileged to be here in the discussion. I'll be presenting some real-world cases and discuss a bit about the real-world data. So without further ado, here are some disclosures. So here's a question. Can a patient older than 70 years be safely treated with CAR T-cell therapy? Yes, no, or yes with special measures. Excellent. So without further ado, we can get started. So here's a case of a patient with multiple myeloma received CAR T-cell therapy. So this is a 78-year-old man with revised ISS stage 2, standard risk, IgG lambda multiple myeloma, who received idecabtagene vicleucel in 2021. This patient had had 8 prior lines of therapy to include belantamab mafodotin as a last line. He also had multiple comorbidities. For example, he had a poor ECOG performance status that was actually disease-related. He had had an NSTEMI and required a stint to his LAD about 3 to 4 months prior to CAR T, and he had a reduced ejection fraction, 40 to 45%, in addition to diabetes. On the right, we see his PET scan findings prior to CAR T and his PET scan findings 3 months after administration of ide-cel, and we have resolution of disease that was found on the PET scan. Here's the response by IMWG response criteria, and on the right, you see the serum M spike essentially declining. We saw that the patient got a partial response really up to 12 months of therapy, and now he's about 16 months or so post-treatment, and he's gotten into a complete remission, doing extremely well and traveling. So what would have been some comorbidities that would have made him ineligible for KarMMa participation? So certainly his poor performance status, which again, I'd like to state was disease-related, his cardiac dysfunction, but he also had prior use of belantamab mafodotin or prior BCMA-directed therapy. So going into some of the real-world characteristics or real-world data, so we looked at a cohort of patients who received idecabtagene vicleucel in the commercial setting. That was 159 patients. As Dr. Kumar pointed out earlier, in the standard of care setting, we're treating a patient population with more aggressive disease features, disease biology. So we had numerically higher number of patients with extramedullary disease. We had about 21% of patients with prior BCMA exposure, and we had more patients with poor ECOG performance status and pentarefractory disease, as you see at the bottom. I'd like to point out that 3/4 of the patients, so 75%, would have been ineligible for trial inclusion. Common reasons for ineligibility were things like organ dysfunction, such as renal insufficiency, prior BCMA exposure, cytopenias, as well as a poor ECOG performance status, among other things. In terms of safety, so here we look at the safety profile of standard of care ide-cel to the KarMMa clinical trial. Overall, the safety profile is very similar. We see that grade 3 or higher CRS was about 3 versus 5%, grade 3 or higher neurologic toxicity, 6 versus 3%. We did identify higher use of supportive measures like tocilizumab, steroids, as well as anakinra in the standard of care setting. The non-relapse mortality was 5%. We had 3 patients who died of toxicity, 2 with grade 5 CRS, 1 with concomitant HLH, and we had a patient with a Guillain-Barré type of picture with an ascending type of paralysis. We also had 3 patients die of COVID-19 and 2 with cardiomyopathy. Here we show responses at day 30, day 90, and best overall response rate. So I'd like to point out that the best overall response rate in our ide-cel population was 84%, which is very similar to what we saw in the higher dose in the KarMMa clinical trial, and the CR or better rate was actually 42%. We did look at what were some factors that were predictive of efficacy or response in patients treated with idecabtagene vicleucel. And as we see here, and as was previously pointed out, prior use of BCMA-directed therapy does appear to negatively impact outcomes, specifically progression-free survival, high-risk cytogenetics, which we included the same as the KarMMa clinical trial, translocation 414, 1416, deletion 17p, A poor ECOG performance status was also associated with an inferior progression-free survival. And interestingly, younger patients did worse. I anticipate this may have been a selection bias because we may have chosen our best older patients, but that's just a thought. And here you see the other variables like extramedullary disease, cell dose, et cetera, that were included in our multivariable model. Certainly this prior BCMA exposure is an interesting thought, especially the sequencing as we've discussed. So we needed additional investigation in terms of approaches. Do we need some type of combination for these patients? Do they need maintenance, as we discussed, and or consolidation? So here I'll be presenting some data that was actually just shown at ASCO. This is our first look at the cilta-cabtagene autoleucel, which was the second BCMA CAR T-cell therapy that was approved, as Dr. Kumar mentioned. Population, again, similar in the sense that we treated a population with more aggressive disease biology. We saw that 57% as opposed to 75% in ide-cel were CARTITUDE-1 ineligible. We saw more patients with extramedullary disease. We had about 7% with plasma cell leukemia. And we actually had less patients who were prior BCMA treated. I'd like to point out that the out of specification rate for the cilta-cabtagene product was about 22%, and about 16% of patients were treated with alternative lymphodepletion. Most received fludarabine Cytoxan as in CARTITUDE-1, but then that was followed by bendamustine in 9% of patients, and then Cytoxan alone and a combination of Cytoxan and cladribine. So that occurred during our fludarabine shortage in the United States. In terms of safety of cilta-cel, I'd say overall CRS and ICANS were very similar to CARTITUDE-1. I wanted to focus more on the delayed neurologic toxicity. So this certainly has been a concern, but we identified that the rate of delayed neurologic toxicity was about 12%, which was similar to the clinical trial. Only 1% of patients had Parkinsonism or Parkinsonian features. The majority of our patients, actually 6%, had Bell's palsy or cranial nerve palsies, and their remainder were non-specific, like dysautonomia, polyneuropathy, PRES, or PML. 2 of the patients died of delayed neurologic toxicity, only 35%, and mostly the cranial nerve patients actually were able to recover their neurologic function, and mostly treated with steroids and IVIG. I'd like to point out that the non-relapse mortality was 10%. Majority of deaths were attributed to infection, although we did have 3 patients with grade 5 CRS, and as I mentioned before, 2 died of delayed neurologic toxicity and 1 of an HLH-like, or the IC HLH-like syndrome. So here we show responses. So the median follow-up is 6 months, so still short, but here we show responses in our entire population, the intention to treat population. I should mention there was 153 patients apheresed, 143 infused, 10 patients did not make it to infusion, mostly due to disease progression. So the best overall response rate, including all alternative lymphodepletion out of specification patients, was 89%, with 56% achieving a complete response or better. And the intention to treat, that was 84% and 53% respectively. We did look at our 12-month estimates for the intention to treat population, that was 67% and 79%. And for the intention to treat, the median follow-up was 8.4 months. Here we show clearly that patients who are infused compared to patients who are apheresed and not infused, so patients who did receive the products obviously had better outcomes, whether that be progression-free or overall survival, as you see. We also did a multivariable model as we performed for our ide-cel analysis and included essentially the similar factors, accounting for a different cell dose for cilta-cabtagene autoleucel in addition to the alternative conditioning chemotherapy. And really in this case, we only found that high-risk cytogenetics, as I mentioned before, 414, 1416, deletion 17p, was associated with inferior survival, so progression-free and overall survival, as well as best response rate. Interestingly, we did not identify differences by alternative lymphodepletion or prior BCMA exposure. We're still investigating the BCMA story a bit more because it's different than what we've seen before. I anticipate, there are some differences in timing of the BCMA exposure. So the median time was more than 6 months in this patient population. There was only 17 patients that were treated, and that was nearly half of what we did with ide-cel. So I suspect we've learned from our experience. But again, we're investigating this further and more to come in our publication. So overall, I'd like to conclude that, in both patients treated with ide-cel and cilta-cel in the commercial setting, these patients have favorable efficacy and safety profiles relative to the clinical trials, despite more than half of them not meeting eligibility criteria. Treatment certainly is feasible outside of the clinical trial, and the patient does not have to meet the criteria to be able to benefit from these now newly FDA-approved treatments. With that being said, I just wanted to thank Dr. Surbi Sidana, Krina Patel, and the entire Myeloma Consortium, and all of you, meeting organizers. Thanks very much.
Thank you very much for the case, but also for the ensuing data, which are impressive. We actually already have a question in the chat for you. Okay. In the end, you talked about the high-risk patients. Yes. High-risk cytogenetics. Is there a particular cytogenetic feature that is the worst? Question from the audience.
Yeah, that's a really good question. We actually ended up combining all of the patients with high-risk cytogenetics because the numbers are not that high to be able to, show a significant difference among the groups. That's certainly something we can look at in the future. Deletion 17p appears to be very poor outcome in any disease, but I can't say that in this patient cohort I have the exact answer. More to come.
Mm-hmm. And then I have a question regarding scores. Of course, you start accumulating data in myeloma about efficacy scores. Are there any scores that may predict toxicity? Because obviously some patients die from the treatment.
Yes, so we've actually looked with the German consortium with Kai Rajewski leading this and Dr. Yulin at Mayo Clinic along with us at Moffitt. We've looked at a KarMMa score, which accounts for inflammatory markers as well as cytopenias. And essentially patients who have a high KarMMa, not only was that predictive of specifically ICANS and cytopenias, but also survival. So that seems to be a nice predictive score. And hopefully you'll see some of it. You've seen some of it at ASH, but hopefully you'll see that data coming out shortly.
Mm-hmm. Thank you very much. There are some more questions coming in through the chat. We'll probably have time to ask our speakers at the end one or two more questions. Thank you very, very much.
Thank you.